So welcome, Constance and Ariana. I'm so glad you all could join us today. Ariana, what time is it for you right now?
Oh my gosh, I don't even know. 9 o'clock, 9 p.m.
Oh, so we're 12 hours difference. Well, thank you so much for joining us in the late evening. We're so glad to have you.
Sure.
So tell me, what got you into healthcare?
Yeah, well, first, thank you so much for having me on. I'm excited to be here and to chat. So I, in undergrad, was pre-med and engineering. So I like to say I got scienced out and decided I did not want to be a doctor. I never took my MCAT. My electives were things like organic chemistry. So it was a lot of science. And so I ended up getting my engineering degree, and I was a programmer, which is very odd to say now. Couldn't program to save my life now. And when I was programming, I I miss talking to humans. And I didn't feel like I was helping people. But when, I graduated, it's been over 20 years now, like healthcare was very much you're a clinician. I feel at the time, or you're not. I think now people are much more aware that there are so many things you can do in healthcare that don't mean you have to be a clinician, and you can help out in just so many different ways. There are so many needs. So I stumbled into a health administration program for a master's, and I went and got my master's in health administration, and fell in love with healthcare and eventually healthcare policy.
Wow. And it's so interesting to see what a varied background you have. Many of the people we've had come talk to us, some knew from day one they wanted to be in it. It sounds like you knew you wanted to be helping people in this aspect in some way or another. Some people simply fell into it, myself included. But I always love hearing kind of where you come from. And you brought up a really interesting point that you don't have to be a clinician or not anymore. In this new world, there are so many other players and stakeholders in the world of healthcare. So can you talk to me a little bit about who those stakeholders are?
Yeah, sure. So, I mean, I like to think of stakeholders kind of in a few big buckets. So there's the provider groups, right? The clinicians, or not, they're not all clinicians, but like the hospitals, the doctors, the nurses, all the other ancillary professionals. Kind of the provider groups is one big group of stakeholders. Another big group of stakeholders are the issuers, the plans, the people who actually pay for healthcare, employers. I kind of put them in that bucket, who's paying, and the government, because they're paying, right? So Medicare, Medicaid, DOD, VA, right? They're paying for healthcare. And then my third bucket is more the life science, public health people. So the pharmaceutical, the manufacturers, and then all the public health people I would kind of put in that bucket. That's how I think of when I think of who's in healthcare. To try to make it simple, I think of kind of those three buckets.
And then
Well, and it's interesting. I was just going to say, you could probably add a bucket around, the ancillary typically have been people, like we'll call them caregivers, right? They might be in pop health or social services, but today the ancillary has become devices that are home-based, consumer-based. They become retail chains where you can walk in and not only get your flu shot, but your over-the-counters. And even like the data, the Googles and the others that are getting into the space, because they can triangulate their current customer needs with future healthcare needs that they have. And so I think it's really interesting. Those buckets would be traditional, but we really need to kind of expand the definition of the ancillary bucket. Perhaps that's the one that's probably most nebulous at this point in terms of where it will be in 5-10 years. And the other point I was going to make, I can remember when it was a big deal to have a physician on an entrepreneurial startup. It'd be like, wow, there's a doctor who's doing startup stuff. And now that is almost a requirement of a healthcare startup to have somebody who has a caregiving background, a clinical background, to understand what it is we're trying to address in a more systematic way.
Yeah, I totally agree. And I would add even a little bit onto that of, as we see this movement into the social determinants of health and really looking at the social service side of care, maybe, that goes across all three of them, right? Like
exactly.
Everybody has to deal with that. So like everything. And when you look at issuers, like I create these buckets, but it's very fungible, right? There are hospitals that are issuers, and there are issuers who buy providers, right? Like we have integrated plans or integrated delivery networks, depending what side you're coming from. And so everything's starting to blur, particularly in the payer provider kind of space. I mean, less so with devices and pharma, that's a little more complicated, but like in that space, everything is starting to blur, which I hope is to the good. I do think that there's benefit in integration. I think, the proof is in the pudding, jury's still out, how well that's going to work.
And even the direct primary care providers that are going to employers, they're taking on risk, including pharmacy risk. I mean, they are like going deep and wide. And interestingly enough, will they then be reimbursed for certain of those members who are actually government program members?
Right.
So this new provider direct to employer or direct to group now becomes more than just a provider system.
Yeah, absolutely.
And you bring up an interesting point, Constance, with the government kind of care and how what role the government plays into it. And for many, many years, we were kind of passive observers to what was going on. But now that we've identified the stakeholders, and we know that the government plays a really big role in that. And we see, the rollout of ICRA, even the ACA about a decade ago, right? These are all these government initiatives that are being rolled out, but in the end, it's affecting the patient. So are we passive observers? And if not, what can we do to engage the government?
Yeah, it's a great question. So I think no one should be a passive observer in healthcare. I think it's super important to engage, and it's something I'm really passionate about, and it's a lot of what I do in my current job. So, the government sits, and as someone who sat in that chair and the chair as a regulator, they sit and they try to come up with the rules of the road for people so that there's a level playing field, one, and also so that the dollars, which are finite resources, are spent appropriately on a quality service that is legitimate, that is needed for a beneficiary, right? We're all paying into Medicare. Medicaid's a little bit different, but Medicare we're all paying into, and it's an entitlement that when we turn 65, it should be there for us to have. So they take the role very seriously of the service needs to be a high quality service and needs to be paid. It needs to be an appropriate payment. And so, but they're sitting, in Baltimore, and they're doing they do a great job, and they put out a lot of, rules, and they're trying to level the playing field, but they can't possibly know. It is not fair or conceivable for them. And staff would tell you this, they can't possibly know everything that's happening. And Baltimore and the DMV, the DC metro area, is very different from places like where I grew up in Texas. Like, it's very different, right? So you can, healthcare is local. And so you can't expect people in Baltimore, even if there are a ton of clinicians who work at CMS, a ton, way more than people think there are. Lots of doctors, lots of nurses there. And there are doctors and doctors in particular who still practice. But again, they're practicing in a particular area. So you can't possibly know everything that's happening. It's just not possible. So it is really important then for the public to engage the agency and to communicate with it and say, this is what works in our community and this is what doesn't work. And here's why, and here's data to back that up. And so it is, in my view, extremely important that anyone in healthcare feels empowered to speak up and comment during the regulation process. Or if it's not in the regulation process, if you have something important or valuable or data to share, reach out and ask for a meeting and go do that. Because they are always willing to listen. Doesn't mean they're going to agree with you, doesn't mean they're going to do what you say, but they're always willing to listen. And so for that reason, I think it's extremely important to engage.
But they must get hundreds of public comments when they put out the request. I mean, are they just tossing them aside? How does that work? Are you going to get a response?
So it's a crazy process, but the agency reviews and responds to every single comment it receives in the rulemaking, in the final rule. Now, it may be bunched. It may be that they got 100 comments about X. So they may say 100 people commented. They're not going to say, Sarah Pugh, you commented and you said, right? Like, it's not going to be like that, but they may say 100 people wrote us about XYZ. Here's, what we're doing. Sometimes there are things, and I'm not a lawyer, but the way they answer comments, again, making it simple, I kind of group it into different buckets. So one answer may be, thank you for your comment, but it's not germane to this rule. So for example, you have the inpatient prospective payment system rule, and you wrote about an outpatient thing. Well, that outpatient thing isn't germane to inpatient, so they can't address it. right? So there's the non-germane. Then there's the things that are germane, meaning they are related to the rule, but they don't have logical outgrowth to be able to do anything about it. So let's say they propose XYZ, you write, oh, instead of XYZ, you should do ABC, but it's related, right? They say, well, we don't have logical outgrowth to do that because it may be a great idea, but we didn't propose that. So everyone else didn't get a chance to comment on it. So if we were to do that, it's unfair because we never saw a comment, right? So there's those. Then there's the, nope, sorry, we're not going to do that. And here's, the 20 million reasons why, right? That's not going to happen. And then there are those that are like, we agree with you. We're going to change. And then I guess there's like a bucket kind of in between the no, we're not doing it. And yes, we are, of like, we agree partially and are going to do this piece, but not that, right? But they're going to answer everything. Again, it may be grouped, but they do go through them. I mean, I remember when I was there, we had a rule in particular that had over 100,000 comments or close to it. And they answered every single one.
I have written in twice and commented. I don't remember, probably around the technology, which kind of brings up another area of engagement. We think of engagement as being, you need to improve Medicaid and this is why, or we need to get reimbursed differently and this is why, because we can't, track or verify the quality measures you're asking about. But there's also this technology side of it that says that's great, but we don't have the infrastructure to be able to implement or account for that. And so I think there's an industry comment as well as sort of a public comment opportunity to get this right.
Yeah, I think that's right. That's right. And to be clear for folks, when you comment, like there is a process, you have to go to the Federal Register. I believe it's federalregister.gov or it might be register.gov. And you click on the rule and there's a place where it says upload your comments and you upload it and it has to be there. And people often ask me like, why is everything so bureaucratic? And yes, it is bureaucratic. That is true, but there is a reason for it. So your regulator should be applying the rules in the same way to everyone, right? That's what's fair. It shouldn't be for Sarah, I'm going to do X, and for Constance, I'm going to do Y, because someone's going to feel not good about that, right? So they're trying to apply it fairly. So the process then to produce regulation and have comment is bureaucratic inherently because they want everyone to follow the same rules. So why do you have to do it online? Well, you don't have to do it online. There's also an address you can mail it to, but most people are online. You put it there because then the register will post all of the comments there. So guess what, Constance, you can go see what Sarah said.
And I have, that is,
of you said,
that's so cool when you can go through and read those other comments. You can see, in my case, what other companies are proposing what, and you can actually kind of go into related regulations as well and kind of, infer like what is the bigger conversation that's going on here, not just in this one opportunity, but in adjacent opportunities that affect industry shift.
So we're kind of looking at what can we as the stakeholders do to engage CMS, right? They've got the phone numbers on the top of the regulations. Every, when things come out, there's a request for public comment. Ariana, to your point, you either mail it in or you submit it online. But does CMS also, actively do outreach in the communities, in the provider communities?
They do. So they do a lot of what they call open door forums, and you can go on the CMS website and subscribe. They have a variety of newsletters or things you can subscribe to. You can subscribe to the open door forums, and that those things typically happen after a rule has come out. They might have open door forums to, ask the community what they think, learn, how things are going over, or post final rule, like how to operationalize, right? Like, so you might have questions about how do you operationalize this right now that it's happened. And so they'll have one just for the nursing homes, for the hospitals, for the docs, like there's tons and they're happening all the time. Probably like honestly more attended by the trades and kind of inside the beltway kind of people.
Yeah. So what are some trades that
go out?
What are some trades that, let's say a consumer could join, and then what are some trades that the industry advocates can join or keep an eye on to kind of see what the comments are and what the positions are?
And even
and brokers. Yeah. So, the big trades, right, are of course the hospital trades. There's a bunch of hospital trades, but the AHA and the Federation are the two biggies. But there are the Catholic Hospital Association, the Children's Hospital Association, the Americans Essential Hospitals. So and the academic medical centers. There's a whole bunch of hospital trades. You have the issuer trades. There's a few. AHIP and BCBSA are the two biggies. AHIP, it does take membership, like actual just people membership, beyond the plans. Now, you don't have the same level of access to information the way the plans do, but there is like people kind of consumer type membership. Really, I think more directed at brokers and stuff, not, patients. Patients, if you're thinking about from patients or consumer point of view, where they tend to engage really is in the patient advocacy group world, right? Like, so they have a disease, or a family member has a disease state they really care about or are really passionate about, and they tend to get engaged in that space, or in like AARP, or kind of like the consumer group. So like Families USA, the National Partnership for Women and Children, right? Like these groups who really bring together patient advocates, consumers together to do things.
How about the employer space?
Employer
space, do they go direct?
No, they have. So they also have their own kind of associations, depending on how you think about it. But there's the National Business Group on Health that has a bunch of large employers, right? There's the ERISA plans. They have ERIC, they have look for ERISA plans. There's like Health Leadership Council, which has a bunch of different companies across, the entire kind of those buckets I talked about at the beginning. So they have providers, issuers, pharma, public health, like they have everybody kind of in there. Then, of course, there's the more traditional business groups who have to care about healthcare because it's a big line item for their members, like the Chamber and Business Roundtable, right? So they also have their own groups. There has been attempts at bringing employer coalitions together to try to drive, better outcomes in healthcare, or push the issuers and the health plans for the plans and providers either for more transparency in pricing or more accountability, in outcomes. They've just never, in my opinion, one person's opinion, gotten off the ground. Like in the same way, like I don't know if they just can't come to agreement. And I think we saw some of that even, although it was in a coalition with Haven, right? Like you had these three behemoths come together and you think they're going to like finally force, right? And then it kind of just dissolves, right? It just never kind of comes together. I think on the employer side, but they do have a ton of groups that they all are active in.
So there was one other place that you and I had talked about in how you can engage. We talked about CMS, we talked about us engaging CMS doing outreach, and then Constance talked about some of the trades. But, Congress plays a role in this too.
Oh, yeah.
So how can you engage with Congress or help influence or just make your thoughts known?
Yeah. So, I worked on the Hill, so I will tell you, they too answer everything, or try to. You can pick up the phone and call your member of Congress any time of the day. There are people there answering the phone, during business hours, of course, all day long. And you can send them a letter. Most members these days, if you go on their website, have constituent services where you can request meetings, you can send information in, you can do a whole host of things, usually through their websites. And you can, look up who their staff is and reach out and ask for a meeting. I should say this, you should be a constituent of theirs, meaning you should either live in their state or live in their district, right? Like they are representatives of their constituents, and they are looking always to do constituent work and help their constituents. So, anyone can reach out at any time, and, members who do it right and their staffs who do it right will get back to people, and we'll try to meet with them, whether in district, in the state, or in DC, although, Zoom has changed everything now. COVID has changed that. Like Hill offices now also do Zoom, which I would have never, if you asked me 3 years ago, oh, Hill offices are going to do meetings on Zoom, I would be like, yeah, no, that's never going to happen. And here we are. So, things have changed, and in a way, it probably makes them a little bit more accessible.
Yeah.
Right? Yes.
Well, certainly, in many of our podcasts, we've talked about what the pandemic has done, and this idea of digital advancement has been huge. The idea that you and I are talking across the world from each other. It's nighttime for you. I'm starting my day, and we're so thankful for that. But you really highlighted some really important things. Many people we've talked to really focus, like you said, on the clinical side or even the technology side. How do you get people into plans? And this is such an important piece of it. It's the policy side. It's how that policy is made. And we are all, looking at this, and we all have our opinions, whether we're brokers or consumers or vendors. And it's really helpful to understand how to reach out, when to reach out, how to make our voices heard. So I want to thank you again for coming, for giving us part of your evening. I know you've got your family, and hopefully everyone can go to bed after this. And I would love to have you back on a future podcast.
Sure, I'd love to do it. Thank you guys for the opportunity. This was fun.
Wonderful.
Thanks,
Have
Ariana.
a wonderful evening, and we'll talk to you all soon. Be well.
Take care. Bye-bye.